Next, I'd like to introduce Dr. Wade Iams from Tennessee Oncology, who's going to enlighten us about the very busy and interesting world of lung cancer and immunotherapy.
Thank you for the opportunity to give this talk. And so when the topic of immunotherapy updates in lung cancer for the last year came up, it was unusual to think that it's actually small cell lung cancer that's had the major innovations in the lung cancer field within the last year. So today I'll talk about practice changes for immunotherapy in lung cancer that have taken place in small cell. So new application of durvalumab and consolidative therapy for limited stage small cell lung cancer, BiTE therapies getting into the clinic in a even bigger way in solid tumors for patients with relapsed small cell lung cancer. And then just a brief bit about antibody drug conjugates, somewhat of a hybrid of immunotherapy, but another exciting data point in small cell, so I threw it in there. So the organization, as I noted, we'll talk about the data that led to practice change ASCO last year. So over the last year, we've had uptake of durvalumab consolidation for patients with limited stage small cell lung cancer. We'll go through the data that's also led to BiTE therapy for patients with relapsed small cell lung cancer, specifically tarlatamab, a DLL3 targeted bispecific T-cell engager. And then a little bit of data on the horizon that's making waves, again, in small cell lung cancer, antibody drug conjugates. Here, specifically, I'll talk about a B7H3 directed ADC called ifinatamab deruxtecan. I'll preface each one with kind of how I felt as that data came out. So starting with the durvalumab data, when it was presented, we were actually participated in the Adriatic study, and there had been a negative trial in Europe using nivolumab and ipilimumab in limited stage small cell lung cancer that was a failure. As that trial was going on, there was a durvalumab tremelimumab consolidation arm that was closed early. So when we finally got the data, I was worried that these were two trains on a collision course, but the results were actually very strong for the use of durvalumab for patients with limited stage small cell lung cancer. As I noted, the study design of Adriatic actually included 3 arms. So patients were randomized to receive durvalumab consolidation for 2 years after definitive concurrent chemoradiation, or placebo, or durvalumab plus tremelimumab, so PD-1 CTLA-4 combination arm that was closed early, and we haven't had the results noted of that durva-tremi arm. Just as a reminder, limited stage small cell lung cancer encompasses stages 1, 2, and 3. Most patients are diagnosed with stage 3 disease. That's just the reality in the clinic with how aggressive and difficult to catch small cell lung cancer is. The primary endpoints were both overall survival and progression-free survival, and consolidative durvalumab improved both of those endpoints. When we look at the characteristics of the patients on the study, there's a couple nuances in the clinic that are helpful when we apply this data. So in standard of care treatment for patients with limited stage small cell lung cancer, the type of chemotherapy is often debated. Do you use carboplatin or should we use cisplatin in the curative intent setting? So here it was treatment physician's choice. You could use carbo or cisplatin. The use of prophylactic cranial irradiation, or PCI, is heavily controversial. Most practices are not doing this anymore for patients with limited stage small cell lung cancer. The trial allowed either, and we can see from the baseline characteristics that about half of patients got PCI in each arm. The chemotherapy was also split about 2/3 cisplatin, 1/3 carboplatin. And then there's controversy around once daily or twice daily radiation and what may or may not be more effective for patients. And so we can also see a split here that 3/4 of patients got once daily radiation, 1/4 of patients got twice daily. So this is very helpful when we apply this data in the clinic, in the real world. So just kind of a note as when we think about clinical trial design in interpreting those results, these real world aspects are very helpful when that rolls out. And of course, when you have results like we saw with durvalumab. So progression-free survival was notably improved in patients who got consolidative durvalumab versus placebo. Again, the durva-tremi arm is not included in the data sets, not public yet, but a median progression-free survival of almost 17 months versus about 9 months. So it's good, but the other thing that I point out with this graph is that we have significant room for improvement. if we're meeting a patient with limited stage small cell lung cancer in the clinic, it's hard to be particularly excited to tell them there's over a 50% chance the cancer is going to come back and be lethal within a year and a half. So we have a lot of room for improvement here, but this is a clear marginal benefit for our patients with limited stage small cell lung cancer. Even more impressive was the improvement in overall survival. So the median overall survival for patients treated with consolidative durvalumab was now up to 56 months, compared to a control of about 33 months, which matches the historical data sets that we had for treating these patients. So clearly there's a benefit in patients with limited stage small cell lung cancer who receive consolidative durvalumab. And then a good segue into our next talk about the real world practicalities of what does this mean in terms of toxicities? Are we going to see more pneumonitis in patients who are treated with an immune checkpoint inhibitor after radiation? So that was the biggest concern going into the study, the rates of pneumonitis in particular. And we see that radiation pneumonitis specifically was very similar in the cohort of patients who received the immune therapy or did not. And then pneumonitis lower on the graph is also highlighted. We see trends to increase rates of durvalumab-related pneumonitis, but not a major difference where we would say we're going to withhold this treatment because of a slight increase in toxicity. The darkening of the bars is grade 3 or greater toxicity or hospitalization or worse level of severity, and we can see that those rates were very low. So we were all reassured. Yes, there is a trend towards increased rates of pneumonitis in patients treated with immune therapy. That's no surprise. But it wasn't a major difference where we would think this is prohibitive and preclude that overall survival benefit we saw in particular. So tarlatamab, or our CD3 DLL3 bispecific T-cell engager, has been a huge change in practice for the lung cancer field, not only because of the type of therapy, so I think it's the second solid tumor BiTE approved, the first was in uveal melanoma, but because of the FDA label requiring observation in an appropriate healthcare setting for 22 to 24 hours, that's put a pressure on systems everywhere, and now in community practice especially, put pressure on those systems to try to deliver this therapy to patients, having good hospital partnerships and being able to manage that unique monitoring that's required. So I'll briefly touch on the efficacy data and then emphasize the toxicity of why the FDA has that label on tarlatamab. So tarlatamab really was a story of Phoenix rising from the ashes of DLL3. So there were antibody drug conjugate programs in small cell lung cancer that got all the way to phase 3 trials in the last 5 years. Rova-T was the lead product targeting DLL3 in small cell lung cancer. It's highly expressed, highly specific. Everybody thought it was going to be a resounding success, and it was a massive failure. There was a lot of pleural and pericardial effusions, some unique toxicity that was seen with antibody drug conjugates to DLL3 in small cell lung cancer. But as a field, we continue to proceed, moved on to bispecific T-cell engagers, and we have notable benefit in administering these therapies. Not surprisingly, what I won't touch on today, but to comment on pipeline is in small cell lung cancer, now we have CAR therapies targeting DLL3. So the field continues to move and try to advance into more aggressive immune therapies for these patients. But tarlatamab specifically, the FDA approval was based on the Delphi 301 study. So this was a single-arm trial. We don't have a comparison with placebo. We just have a comparison of 2 different doses of the product, 10 milligrams and 100 milligrams. So the way that it's administered is a 1 milligram step-up dose and then a jump to a higher dose, either 10 milligrams or 100 milligrams. Interestingly, the study was in the 3rd line or later, so patients had to have had platinum doublet therapy and another line of systemic therapy before they were included on this clinical trial. And then the FDA approved this in the 2nd line or later because of the unique durability of benefit that was seen on this study. So ultimately, our 10 milligram dose is what's FDA approved. But when we look at some curves here, you'll see 2 curves. That's 10 milligrams versus 100 milligrams, not tarlatamab compared with another drug. So exciting development in in relapsed small cell lung cancer. These are waterfall plots. So each vertical bar is one patient experience, and the y-axis is the amount of change in the target tumor lesions. So what % decrease in the target tumor. And we can see very similar plots between 10 milligrams and 100 milligrams. The response rate in the 10 milligram cohort was about 40%. DLL3 expression is near ubiquitous in small cell lung cancer. It was measured on the study and over 90% of tumors expressed it. So FDA doesn't require DLL3 IHC to use tarlatamab because we know that it's expressed in the vast majority of tumors. When we look at the progression-free and overall survival, again, the two curves are just different doses of tarlatamab, and really there's no difference between those two, but we saw notably more toxicity at 100 milligrams of a bispecific T-cell engager, so that's why the 10 milligram dose was carried forward. So the median progression-free survival, again, this is third-line small cell lung cancer, was about 5 months. So a lot of room for improvement. But very impressive was a median overall survival of 14 months. So really that overall survival in third-line small cell lung cancer is what's pushed me and most of my colleagues to really trying to get this treatment for patients who can tolerate it and have the support and willingness to travel for the observation, which are all big factors, but to try to get this therapy to as many patients as we can within our practice. When we look at the reason for the label, this is a busy slide, but I'll walk you through it. We have unique toxicities associated with bites and CARs. So this is CRS, or cytokine release syndrome, and ICANS, or immune cell associated neurotoxicity syndrome. We'll focus just on the 10 milligrams, which is the top of the slide. We can see just generally a quick glance, higher bars on the 100 milligrams. So just more CRS and ICANS. That dose was not carried forward because the efficacy was similar. So do the less toxic one with the same efficacy. But we still see rates of a little over 50% of patients experienced grade 1 or 2 CRS, cytokine release syndrome, with one of the first 2 doses. So the visual moving from left to right are the initial doses and then subsequent doses over time. And we can see those tall green bars at the beginning are why the FDA has the label of the special monitoring for the first 2 doses. So not only is it required for 22 to 24-hour observation in an appropriate healthcare setting, it's also required that patients have a caregiver with them for the first 48 hours and be within 1 hour of an appropriate healthcare facility. So reaching rural patients is an issue with this therapy, and we need to have both good hospital partnerships and good resources to support our patients who really don't want to drive downtown. We see that in Nashville and Chattanooga, and tons of patients, and getting them access to these treatments, especially as they come along, is critical. Another anecdote that I think is helpful for all of us just thinking as these bites come down the line, and as noted, there's several coming in prostate cancer. But for example, our process in Nashville is different than Chattanooga. In Chattanooga, our malignant heme service agreed to take care of these patients getting tarlatamab as the primary service. In Nashville, our malignant heme service for our hospital said, we're not going to take these patients because then you're going to send us the prostate cancer patients and the breast cancer patients. And these are coming for patients with other solid tumors. So we have to have a process improved and ready to administer for these patients. So ultimately, our hospitalists agreed generously for the time being to be the primary service for our Nashville patients, but the malignant heme service consults. That's just to say that the field knows that BiTE therapies and other immune therapies are coming for many patients with solid tumors. And I've seen a good amount of investment, but there continues to need to be improvement, especially in the community, for getting these therapies to patients in more rural areas. So that's continuing to be the primary next step for the field. So I couldn't resist putting in some ADC data, although even patient counseling with antibody drug conjugates, I call it more of a precision chemo. Antibodies in the name, so I decided it was okay to include for this forum. But ifinatamab deruxtecan, or IDXD, and really several different ADCs in patients with small cell lung cancer is a new horizon. I mentioned the DLL3 failure of ADCs, and we moved on from that. But there are other targets for antibody drug conjugates. In this case, B7H3 is another highly expressed and specific protein on the surface of small cell lung cancer tumor cells that's shown good success in early trials. So IDXD is directed at that B7H3 or CD276 epitope on the surface of small cell lung cancer cells. And we have a linker to a common payload with deruxtecan. We're familiar with this from numerous other ADCs. And the IDeate-1 study was just, there's 2 arms, but it's different doses. I apologize for the disappearance there at the top. That happens with this slide sometimes. But it was 8 milligrams per kilogram on the top box of IDXD and 12 milligrams per kilogram on the bottom box. So again, not a comparison between 2 different drugs, rather a comparison of doses of the same drug. So as we'll see, there's some interesting and not surprising takeaways that we're processing as a field when we think about IDXD for patients with relapsed small cell lung cancer, namely higher efficacy with 12 milligrams per kilogram, but also clearly higher toxicity. So what does that look like? And we'll talk through. The 8 milligrams per kilogram dose had a response rate of about 26% in this patient population. The 12 milligrams per kilogram dose had a response rate of over 50%. So tarlatamab, I noted, that was FDA approved with a response rate of 40%. Lurbinectedin, which is it's just a transcription inhibitor, cytotoxic chemo, was approved for patients with relapsed small cell lung cancer with a response rate of 35%. So really that 55% number is eye-catching. But keep that in mind because we'll look through the toxicity as well. And that's been a big point of discussion in this drug development program is do you continue the higher dose with more efficacy and accept the increased toxicity, or do you go with the lower dose? And the spoiler is ultimately the higher dose is what's being pursued in randomized phase 3 trials. But PFS and OS, we also saw differences by the dose. So 12 milligram per kilogram, PFS a little bit longer at 5.5 months compared to 4.2 months for a little bit lower dose. OS also a little bit longer, almost 12 months compared to 9.5 months for a little bit lower dose. You'll recall the median OS for tarlatamab was about 14 months. And so that seems to have a stronger impact on the immune system and more potential for durability. So a lot of us in the field look at tarlatamab similar to checkpoint inhibitors in non-small cell lung cancer patients. You really just want to give your patient the opportunity at that treatment in case they have incredible durability, knowing that many patients won't. So these ADCs are different. They're not as immunogenic as other treatments, but like I noted, exciting to have this development in small cell lung cancer. The toxicities we can see are notably increased for the 12 milligram per kilogram dose. So here the shading is reversed. Sorry, it's confusing that one trial used dark shading to indicate grade 3 or greater. This trial is using light shading to indicate grade 3 or greater. But you can see just from a quick visual, even these graphics that are really hard to process, there's notably more light shade for our 12 milligram per kilogram dose. So we have more GI toxicities, more significant cytopenias at 12 milligrams per kilogram, but we did see increased efficacy at those doses. So ultimately, randomized phase 3 studies in patients with relapsed small cell lung cancer are using that 12 milligram per kilogram dose, now looking at IDXD compared to dealer's choice standard of care chemotherapy. So overall, we've walked through consolidative durvalumab, a checkpoint inhibitor application that's new in lung cancer. So next year's talk, there will be no new checkpoint inhibitor applications in lung cancer. We've got them in limited stage small cell, extensive stage small cell, resectable non-small cell, unresectable stage 3 non-small cell, and metastatic non-small cell. So now we've got full penetration of immune checkpoint inhibitors in the field of lung cancer. BiTE therapies, I'm sure we'll be hearing a lot more about for all different types of solid tumors. So have those on the radar. We've had those introduced in small cell lung cancer. Not surprising, those are trying to move up to upfront extensive stage small cell lung cancer, also trying to move into the limited stage small cell lung cancer space. Ongoing efforts in non-small cell lung cancer as well with BiTE therapies. I just referred a patient of mine for a phase 1 trial for a non-small cell BiTE. And ADCs are coming as well. So numerous ADCs, admittedly not as immunogenic, not as much potential for durability, and some of the efficacy data is not quite as impressive as what we see with our novel immunotherapies, but it's exciting in small cell, so I threw it in there. Thank you for your attention. Any questions?
Any questions for Dr. Iams? I have one. What's the data for the relative degree of senescence and T-cell dysfunction in lung cancer that inhibits all these things?
Oh, that's a great question. I really don't know. But the what will be interesting to see will be more CAR T data in lung cancer as a whole, and some TIL data. I know there's a talk coming about TILs in lung cancer. What we've faced in clinical trials with CAR T and TILs for patients with lung cancer that's a little bit unique is the ability to bridge these patients through the manufacturing process. So I've referred a couple patients for CAR T trials, and both died during the cell manufacturing process. So, maybe you could say it waited too long to refer for these therapies. That is probably part of it. But I think once lung cancer gets to these very advanced and aggressive stages, there's such a degree that it's overriding the immune system. Is it senescence? Is it just the unrelenting aggressiveness of the disease that we can't overcome? It's hard to tell.
Is there allo CAR coming for?
There are allo CARs coming for lung cancer as well. That would be a key solution. Yeah.
Thank you very much.